Okay, so we're about to start the webinar here, and welcome to the show. Welcome to the webinar. Welcome to the webinar, How SmartPilot View Turned Me into a Smart Pilot for My Patient. My name is Peter Bellhammer, and I'm the responsible marketing manager for anesthesia OR in Dräger in Region Europe. I'm very pleased to be able to host today's webinar on the topic of SmartPilot View and the important topic of anesthesia dosing in the OR. I'm very happy to see so many registration. In fact, it's over 600 who has registered for this webinar from all over the world and representing more than 50 different nationalities. You, as well as me, must find this topic very interesting and important. I believe it may have a great impact on the care of the anesthetized patient. You will automatically receive a copy of today's slides and access to recording within the next couple of days. But important for doing this, you need to have checked the boxes for the GDPR regulation. It's for the data privacy reasons, and you must look for an email from Dräger company. And the subject is just one more step. Please confirm your email. If you do this, you will be able to receive this the slides from today's show. Some legal disclaimer. The webinar presentation is for information purposes only and has no commercial background. It has neither a influenced or the content of the presentation or taken measure to the sole responsibility for the content of the presentation and the webinar lies at the author. All views expressed or information given are those of the author and or in no way attributed to Dräger. Before we start, please note that this webinar is recorded and the recording will be distributed afterwards at the end of the webcast. Some audio check. Please raise your hand if you hear my voice properly. And with that, you press this little button up here and you can see that there is a hand. And can we see this in the group? There is some hands coming up. And cancelled. Due to some timing reasons, we need to take all the questions at the end. And please write your questions in the questions field. All the questions will be answered by the speaker at the end of the presentation. In case of we run out of time, all the questions will be addressed to the speaker and will be answered afterwards. And you enter your questions on this side, on your little toolbar on the questions. Yeah. Your expert presented today, how SmartPilot View turned me into a smart pilot for my patient. Dr. Rik Carette is a consultant anesthesiologist at OLV Hospital in Aalst in Belgium. He has been working for more than 20 years as a doctor and has over 10 years of clinical use of the SmartPilot View. I believe that this makes him a world-leading expert of using decision support for improving anesthesia care and the patient outcome. Dr. Carette has also a solid foundation in research with over 20 published studies on various anesthesia topics. And with this, I hand over to Rik Carette. Please, are you with us?
Yes, I am with you, Peter.
Very good. And then I will hand over the presentation for you.
So far, nothing is happening here.
Yeah. Yes.
Okay.
Yeah.
Yes, here we
Yes.
are.
Perfect.
So, ladies and gentlemen, first of all, Peter, thank you for the kind introduction. Welcome, ladies and gentlemen, to this morning, noon, or evening webinar, depends on wherever you are. When I am talking about my family, about homegrown tomatoes or off-road driving, I may have a biased opinion. However, in this meeting, my opinion, what I tell you is my own opinion. It's not influenced by Dräger, and as much as there is evidence, I will show it to you. What do I do for a living in everyday life? I am an anesthesiologist giving anesthesia for abdominal, vascular, thoracic, gynecology, and urology surgery. I work with inhaled anesthesia most of the times, and I use opioids, fentanyl most of the time in bolus administration or remifentanil target controlled infusion. I use monitoring of EEG and also nociception most of the time. During this lecture, we will talk about the device called SmartPilot View. I sometimes may call it SmartPilot, and when you see it on my slides, it can be abbreviated as SPV. You may have noticed that I use opioids. There's a lot of debate going on, but I believe there is some evidence to use opioids. Anyway, today we will not be able to have that discussion. SmartPilot View is a tool that works with opioids. So if you never ever use opioids and never ever are planning to do in the future, this lecture may just not be for you. So, excuse me, I am trying to get a full screen view here, but it doesn't seem to work. Anyway, 1 year ago, I received this email from a patient. So she had a really bad experience with an anesthesia, and a few days later she turned up again and she had me as an anesthesiologist, and fortunately for her, that experience was a little bit better. So afterwards, I went into the files to compare both cases. The first case, it was with a colleague of mine and a third-year resident, and the next case where she was more happy, it was me with a first-year resident. So you could say the first case lasted a little longer. They gave less opioids and they gave more inhaled anesthesia. Also, they needed some phenylephrine, while in my case, it was not necessary. So some time ago, almost 20 years ago, I used to work like they did in the first case. At that time, when I was a resident, we were studying fresh gas flow sequences to reach 1.3 Mach as fast as possible and to keep 1.3 Mach for an hour with the lowest number of fresh gas flow changes. So at that time, this was how I used to work. So I thought that hypotension was a synonym of anesthesia. If you don't have hypotension, you don't have anesthesia. If patients become hypertensive, you give them opioids. If they become hypotensive, you give them vasopressors. There's 200 milligrams in a vial of propofol. That's because that's the dose you have to give to a patient. That's what I thought at the time. They invented the Mac, so let's use it. Always give a patient at least 1 Mac of inhaled anesthetics. needless to say that my anesthesia went up and down all the time, like a yo-yo. Is this a problem? At that time, I didn't feel like. Also, if you look at the rich literature in the Medline, at that time it wasn't really of a problem. But the last years, there is becoming more and more evidence that this thing of giving patients a wrong dose or an overdose may be a problem. So, for example, if you do a Medline search on hypotension during anesthesia, you find more than 17,000 articles talking about the effects on renal function, talking about myocardial ischemia. Also, there's a lot of debate on postoperative cognitive dysfunction and postoperative delirium, more than 8,000 hits. Anesthesia has some cerebral effects. How to avoid them is still under debate, but I believe in the future we will know more about that. Also, if you give an overdose to patients, if you need vasopressors for every patient, there is a cost of this. If you give patients too much, they will tend to sleep longer. Turnover times will increase, and also this has a cost. Lastly, inhaled anesthetics are greenhouse gases, so they have a global warming potential. If you could decrease the dose, you will have an effect on the environment. So what can we do? I think this is the thing we can do. We can give our patients balanced anesthesia. We can combine different drugs in order to give of each drug a smaller dose. This way we can decrease side effects, we can have less waste, we can have less use of vasopressors, we might have an early recovery and maybe even increase patient satisfaction. There are a few articles on this where they say SmartPilot View can help you to reach this. So you have better postoperative outcome, you can reduce the dose of some anesthetics. But unfortunately, there's only 4 articles right now published. I believe there's also some circumstantial evidence. And if we look for it, we have to go into the pharmacology literature. So what we are trying to find is how do drugs interact, and how can, if you know about this interaction, how can it optimize your anesthetic drug interaction administration? So what we know is that some anesthetics work synergistically. So 1 + 1 = 3. So we will see how you can represent it on a graph. Also, you can give it a number. This is called NSRI, Noxious Stimulus Response Index. And then we will talk about how a display can help. Please keep in mind that in pharmacology, they make models. And models are developed and studied in a population. So they predict a certain response, a certain effect. So the model may work or may not work for your individual patient. You could check this with a measurement. First of all, synergy exists, and it can be quite substantial. Only a small remifentanil effect site concentration of 1.3 nanograms per milliliter already reduces the CE50 of sevoflurane and propofol by 50%. That is, in my eyes, that is huge. So synergy exists, let's try to use it. But how? Typically, if you study synergy, you will come up with these graphs that these are called dose response surface graphs. That are 3D graphs with on the x-axis the opioid, on the y-axis the hypnotic agent, whether it's an inhaled agent like sevoflurane or desflurane, or it could also be propofol. And on the z-axis, they have the predicted effect. This graph you see here on your screen is a two-dimensional graph. So actually, they took the three-dimensional graph and looked at it from the top down. This way, you only see 2 dimensions. Those lines you see here, they are called isoballs. Now, every point on an isoball, let's take the yellow isoball as an example. Every point on the yellow isoball represents a combination of effect site concentration of an opioid and of an hypnotic agent. Every point on this isoball represents a combination of these two that gives you the same predicted clinical effect. So in this case, every point on the yellow isoball gives you a 95% probability of no response to intubation. So you can have this calculated probability with a very low amount of remifentanil and a high amount of sevoflurane. You can also have exactly the same predicted probability with a high amount of remifentanil and a lower amount of sevoflurane. This two-dimensional graph can be more simplified. Sort of speaking, you could make it one-dimensional. You could give it a number, and that number is called the noxious stimulation response index. It's a number going from 100 to 0, and if you are below 20, you will have a predicted anesthesia that is a predicted probability of tolerating highly painful stimuli. So there has been studies going on this NSRI, and it proves from this study that NSRI was better in predicting response to certain stimuli like shake and shout, tetanic stimulation, laryngeal mask airway insertion, or laryngoscopy. That NSRI proved to be better at predicting whether or not the patients tolerated these compared to, for example, BIS or entropy or the effect site concentrations of inhaled agents or remifentanil. This may look a little complicated, and some of these articles are very almost unreadable. So why do we need something like SmartPilot View? It could translate it into everyday clinical practice without having to read all these articles, without having to make all those difficult calculations. And that's when I believe a SmartPilot View comes into play. There's currently on the market 2 types of SmartPilot View. There's the one with a separate screen. This one is in use with older versions of the Zeus and with the Perseus. And then there's a one on the newer versions of the Zeus, and it's a split screen. So it's information that pops up on the screen. So you can see it here. If you push the button on the right hand, then there it is with all the information. So there's a lot of information on the screen. Let's take a quick look what we can see. First of all, we have in the left upper corner, we have the patient characteristics. So of course, in pharmacology, these matter. So these are entered manually when you start up your Zeus or your SmartPilot View. So it's important that you enter these correct. Also for intravenous pharmacology, it's important that you enter the gender right, because there is a difference between male and female. Next, here we have the calculated effect site concentrations. So where does SmartPilot View get this information from? Whether it's incorporated in your anesthesia machine or it is connected, it gets the effect site concentration of inhaled agents from the ventilator, from the Zeus. For intravenous drugs, it can be two things. Or the SmartPilot View is connected with syringe drivers, and then it gets this information from there. Or you can also manually enter a bolus dose or an infusion rate. Based on these characteristics, SmartPilot View then calculates effect site concentrations. This is what we have been talking about a few minutes ago. This is the dose response surface graph with isoballs, and they also have a name. So for example, the upper isoball here is the MAC 90 isoball. So if you are on or above that isoball, you have a 90% chance of not moving or not responding to a certain surgical stimulus. You may notice that we have some dots here. We have the orange dot, we have a black dot, and we have a white arrow. Also, we have this white line. Actually, this is the trajectory that our anesthesia has been gone so far. The orange dot is, as you can see here, where we are now, calculated anesthetic depth. The black dot is where we will be in 10 minutes, and the white arrow is where we will be in 50 minutes, under the condition that nothing changes, under the condition that we don't give an extra doses of, for example, fentanyl. Also, you have here in the corner, you have a little display predicting your time to toss, time to responding to tolerance of shake and shout. So this gives you an indication, again, if nothing changes, when your patients could be awake. Next up, we have the noxious stimulus response index. So it gives you the number, and you see here that we are on the MAC 90 isoball, so our NSRI is around 20. One important feature of the SmartPilot View is this. This is here you have time 0, and this is a prediction for 20 minutes into the future. So it predicts what your effect site concentrations will do. So we have a entitled target set for desflurane. So if we don't change it, it will stay steady. We have given a bolus of propofol and fentanyl. So of course, concentrations will keep going down. Also, we have a prediction in the future what our NSRI will do, as we have the prediction here in 10 minutes, in 15 minutes. That is a very, in my eyes, a very important and very useful feature of SmartPilot View. On the split screen, you have exactly the same information, albeit a little bit more compressed. So we have the patient characteristics, we have the calculated effect site concentrations, we have our dose response surface graph, we have our NSRI, and so what can we see on the, for example, we can see both additivity. So we have nitrous oxide, propofol, and desflurane. They all work in an additive way, and we have the synergy over here. So we can see that over here, that would be, according to pharmacology, the area of the maximal synergy. Also, we have our prediction. What would happen if? So for example, right now we had an induction with quite a lot of opioid. I think it's remifentanil. We gave propofol. We gave an extra dose of propofol, and now we are here. What if we would set our entitled target for desflurane on 8.4? This is what would happen. So we would be quite a lot above the MAC 90 isobol, and probably our patient would be too deep. What if we would give a manual bolus of sufentanil? This is what would happen. Instead of in the next few minutes diving under that MAC 90 or tolerance of laryngoscopy 90 isobol, because our sufentanil effect site concentration is decreasing, we gain another 15 to 20 minutes above the isobol. That's what happened. That's what would happen if we at this time gave another bolus of sufentanil. Also, we see here why it's useful to take into account time to peak. What would happen if we 1 minute after giving sufentanil would already start with propofol? 1 minute after sufentanil, if you see on the bottom here, we would not have reached our peak effect site concentration. As a result, we would only be here on the dose response surface graph, and we would need quite a lot of propofol to reach or to go over the MAC 90 or TOL 90 isobol. So if we would wait till we have reached our peak effect site concentration, which for sufentanil is around 5 minutes, then we are here, and then we need much less propofol to reach our predicted probability of no response. So let me show you one example. So this is a 70-year-old lady for a nephrectomy. We start with remifentanil. We set our target at 1.8, I guess. Almost immediately after that, we also start with a bolus dose of propofol, because both remifentanil and propofol have a time to peak that is below 2 minutes. There's no use in waiting 5 minutes after starting remifentanil before giving your propofol. And you see here, we give only 80 milligrams. We are now the orange dot, and if nothing happens, in 10 minutes we will be right here again. So if nothing else would happen, in 10 minutes patient would be definitely awake again. So before we intubate her, we give a small extra dose, and we give 30 more milligrams. In the meantime, we have reached our set target for remifentanil. This is immediately after intubation. So you can see here that right now we are below the MAC 90 isobol, but this lady, you cannot see it on this slide, but she had a BIS number of only 35. So this was enough for her. Next up, we will start our inhaled anesthetic. We choose desflurane, and we set a target of 3. So what would happen? You see it here. If we do this, our NSRI will first go up a little. That's because the effect site concentration of propofol is decreasing, and because the effect site concentration of desflurane is only increasing slowly. Also, you can see it here. We will go towards our set target. And this is after 10 minutes. So now we have a steady target, desflurane. In the meantime, we decreased our effect site concentration for remifentanil a little bit. Propofol is almost gone. We are here, the orange dot. Again, we have a slightly higher NSRI than expected, but this lady had a BIS value at this moment of 42, so I think it was good for her. And we are working with 2 targets, so if we don't change anything, our predicted anesthetic depth will not change either. So that is why the orange dot, the black dot, and the arrow are all on the same spot. When would when would I consider using SmartPilot View? It could help us in dosing opioids. How long does a bolus last? When do we give an extra bolus? It could help us decreasing hypnotic drugs. It could give us an idea on the synergy. It could also help us in the situation where you have reached your end-tidal target of inhaled anesthetic, but somehow the patient is still moving. It could also help us explaining why at the end of the operation we have switched to a high fresh gas flow. Our end-tidal inhaled anesthetic concentration is 0 or close to 0, but the patient is still sleeping. And it could help us in choosing a combination of hypnotics and opioids that is best for a short wake-up time and for patients waking up with a smile. So first, the opioids. This is a representation of what happens when you give to a standard patient a bolus dose of 15 micrograms of sufentanil or 150 micrograms of fentanyl. You see that we would have that bolus dose of that amount of opioids has only a short-lived effect. In a little bit over 20 minutes, the effect site concentrations will be almost 0 again. If we would give 10 micrograms of sufentanil or 100 micrograms of fentanyl, and then we set a target controlled infusion, and we set our target at 5 nanograms per 5 micrograms per milliliter propofol, then with sufentanil we would only be just above the toll 90 isobol, and with fentanyl we would not get above the isobol. We will not even get above the isobol. Also, you see, immediately afterwards, the effect site concentration of the opioid is decreasing already, so you would have to do something else. So what if at that time you gave an extra bolus, let's say 10 micrograms of sufentanil, then you would gain almost or more than 50 minutes above the toll 90 isobol. That's what you see here. In the case of fentanyl, you would not gain so much time, but it would give you some time above the toll 90 isobol, where in the case you did not give the extra bolus, you would not be able to go over the toll 90 isobol. So by how much can you decrease your dose of your hypnotic if you work with synergy? That is a little study that we did in our hospital. So we went surfing down the isobol. We gave patients a high concentration of inhaled anesthetic agent, desflurane, combined with a very small amount of remifentanil. Then we gave them an intermediate end-tidal concentration or effect site concentration of desflurane combined with an intermediate effect site concentration of remifentanil. And then we gave them a lower end-tidal or effect site concentration of desflurane combined with a high concentration of remifentanil. And this is what happens. All three groups had a BIS value that was between 40 and 60. So in all three groups, we gave a safe anesthesia in order to avoid awareness. So there's a lot to gain if you're working on a synergy. So how come my patient doesn't wake up at the end of the operation while my effect site concentration, while my end-tidal concentration is 0 or close to 0? How come I have reached my end-tidal target for inhaled anesthetic agents and the patient is still moving? That is because, according to the models, the effect site for inhaled anesthetic agents is the central nervous system. And you can see it on the SmartPilot View. Your end-tidal, for example, sevoflurane or desflurane, isn't always equal to your effect site concentration of inhaled anesthetic agent. This is called hysteresis, and this explains the effect you have on responding or not responding the patients. So as you can see here, we already reached our target end-tidal, but we didn't yet reach it as to the effect site concentration. That is the explanation of the phenomenon that we all experience quite a lot. So how about time to wake up? I showed you this on the SmartPilot View in the corner. So if you have a prediction that your patient is waking up in less than 5 minutes, of course it's better than this. Which type of the synergy is the fastest? For a fast wake up, your anesthesia consists ideally of a combination of a large portion of a drug with a fast offset and a smaller portion of a drug with a slower offset. So in this case, the more remifentanil you give, the less hypnotic you will need, and the faster your patients will wake up. Of course, you want also your patients to wake up in a comfortable way. You can do this in a slow way, or you can do it in a fast way. If you're working in a fast way, you could use remifentanil and leave. You can leave your infusion on a low speed, or you could give an extra bolus of sufentanil or fentanyl at the end in order to have a little bit of an effect site concentration left. This will not have a substantial influence on your wake-up times. Unfortunately, in some cases, we cannot use SmartPilot View. That is because we use pre-medication, we use other drugs that are not incorporated in the library of the SmartPilot View. Currently, there's only propofol, sevoflurane, desflurane, nitrous oxide, and for the opioids, there is fentanyl, sufentanil, and remifentanil. If we use a local regional technique, this has an influence on our anesthetic depth of our patient, but is not incorporated in the models. If we enter the wrong data, patient data, or if we enter the wrong bolus that we gave, our calculated data will be incorrect. Also, there's limitations in patient demographics. So there are certain margins of age, BMI, in which SmartPilot View works and does not work. Also, the models are not accurate for patients with underlying disease. In my humble opinion, there's also room for improvement. There could be incorporated new interaction models, for example, with dexmedetomidine. Also, there could be there are now new target-controlled infusion models, for example, for obese patients, which would be useful. So this is an example of how SmartPilot View may not sort of work. This is a 60-year-old patient with Steiner's disease. So we have here a very high noxious stimulus response index. So the predicted probability of not responding to a surgical stimulus was, according to the model, very low. But if you see the BIS value, it is too low. So even this was an overdose for this particular patients. So also with healthy patients, there is this thing called patient variability. SmartPilot View is based on pharmacological models, and these models are developed for the population. So your individual patients may have a response that deviates more or less from what is predicted for the population. And if you see a small dot like this on your dose response surface of your SmartPilot View, sometimes, or you may, in the back of your head, you may think that it's better to see it like this. Also, this area is the area where most of the studies have been done. So if you go over here or over here at the edges of the dose response surface graph, it becomes more and more extrapolation. And if you are working there, it may even be a better representation to have it something like this. So what we always have to keep in mind is that pharmacology is giving you a prediction for a population. This is the case with noxious stimulus response index. It's also the case with MAC. One MAC tells you that 50% of the population will not respond to a surgical stimulus. It doesn't tell you anything at all about your individual patients. So this is the case with SmartPilot View as well. On the other hand, you have measurements like EEG and nociception. They work for an individual patient, but they don't give you any prediction at all. So in my eyes, combining a predictive tool like SmartPilot View with a depth of anesthesia monitor is the golden standard. And that is what I do every day. I work with SmartPilot View and I combine it with a BIS monitor. And in this way, it is very, very nice to work with. And then we can end up with something like this. We have an effect, a target concentration of desflurane. We have a target concentration of remifentanil. We have an NSRI that is sufficient according to the calculations. We have a BIS value that is adequate. We have very, very stable hemodynamics. And then you see here, if we don't change anything, we could stay on this exact spot for hours and hours. So you see orange dot, black dot, and the arrow are all in the same position. And still, we would have a predicted wake-up time that is less than 5 minutes. So no matter what would happen, if we continue this for 5 minutes, for 20 minutes, it will still be the same. So how do I suggest if you would start to work with SmartPilot View? First, you could use it just to see the calculated depth and the composition of the anesthesia you are giving right now. The next thing to do is to combine it with a depth of anesthesia monitor. So if you see on the SmartPilot View that your anesthesia is way above what you would need it for a population, you see this, you see it on the SmartPilot View. And if you combine it with a depth of anesthesia model that says indeed your anesthesia is too much, you're overdosing, then you could start fine-tuning, and this would result in an improved hemodynamic stability. This would give you shorter wake-up times. It would allow you to titrate your opioids better, and it would definitely result in a reduced drug consumption. So after 10 years of using SmartPilot View, I could say it has learned me a lot. Maybe I don't need it anymore because now I know a lot of things about pharmacology, but I still want to keep it. I like to use it to demonstrate pharmacology to residents. I even like to demonstrate the tool itself because I think it's wonderful. For myself, I like to use it also in the future to experience new models and new drugs that hopefully will be incorporated. Having said that, now I think it's the time for questions, and I thank you all for your attention. Over to Peter again.
Yes, thank you, Rik, for the fantastic presentation. As always, it's very interesting to hear your insights of how to use the SmartPilot View and your presentations of the different scenarios on how to use it. I think a lot of people have gotten some insights on what can be done to improve things in the future. So, do we have any questions in the Q&A session here? Yes, there is some. First, a simple one is SmartPilot View available for Atlan A350, and yes, it is. It's available from for Primus, Perseus, and Zeus, and also Atlan. And the next question would be for Rik. Can dexamethasone or clonidine be integrated in SmartPilot View predictions? Thank you for a very interesting presentation. Yes, so can dexa and clonidine be integrated?
Technologically, it would be feasible. It all depends on, one, there should be an interaction model developed and tested, and two, the software should be changed according to these interaction models, but it is definitely possible. But yes, according to me, the first step would be to do these interaction studies, and they are quite a lot of work.
Absolutely, you're right. In theory, it would be possible to integrate it, but it is also depending on the clinical studies that needs to be performed. And we, as a company, Dräger, we cannot perform this kind of studies. It can only be performed by the researchers. So we are using just the information that is available from the research and science out there. So if someone is interested in doing some research of this, we would be very happy, because I think it's an important thing when new drugs are developed and used in anesthesia. So there is another question here. Have you used wake up test together with SmartPilot View?
That's a very interesting test, and actually I did.
Yeah.
We only did a few times because due to organization of our operating theater, SmartPilot View is not available in our neurosurgical ward. So we had to ask the neurosurgeon to move to another operating theater. And there we did a SmartPilot View, and it was just amazing. So we could predict the wake up time within less than a minute.
Oh, yeah, that's exciting. I also have a similar experience when I was using it with a patient, and the predictability was fantastic in my opinion. Also, the next question would be, is it compatible with the Primus? Yes, it is compatible with Primus. And a question for Rik here. What about ketamine? Does it interact with others, and how is the result?
Ketamine interacts, that's for sure.
Yeah.
How it interacts, I don't know for sure. Therefore, we would need an interaction model. What I can say for sure is that it's not integrated in SmartPilot View, so it will have an effect, and the effect will not be calculated. Moreover, but apart from this topic, we know that ketamine does not have a clear effect on BIS monitoring, so it would be very difficult to manage a patient with ketamine.
Yes, I agree, but the interaction models needs to be studied a bit further. I would say also, but there's a lot of people using ketamine out there, so I do get this question a lot, and I would be happy to say yes, but then we need the studies also to be able to support it. Yeah.
If I may, Peter, from
Yeah.
a pharmacological view, there's also the problem with ketamine is that people use it in a lot of different ways. Some give a bolus at the beginning of surgery, some give a bolus at the end of surgery, some people use a continuous infusion. So if you have to study all those different ways of dosing it, it would become an enormous work. So
Yes.
compared to remifentanil, where everyone is giving it as a continuous infusion, it's difficult, it's complicated.
Yeah. Absolutely, I agree, and now the questions is pouring into the chat box here, so we will see if we can make time to use the. Here is one question from Rowan Jackson. Based on your experience, your end-tidal desflurane is only 3.5%, which is around 0.5 Mac. This is due to high remifentanil dose, or what? What?
So I used to never go under 1 Mac in the past.
Yeah.
Because I started working with SmartPilot View, I saw what you can do with Synergy. I use it in combination with the EEG monitor to make sure that we don't have any awareness. We were able to reduce our MAC to a range from 0.5 to 0.7 in almost any case. So apart from giving anesthesia to children where we do an inhalational induction, I never ever give more than 0.7 or 0.8 Mac to a patient anymore.
Okay. Well, thank you. We have another question from Malene in Denmark. What is your experience using it to patient undergoing only sedation? Have you used it?
No, I don't have any experience with that. I know that the studies were done for patients undergoing heavy stimulation like laryngoscopy, like surgical incision. So there are these interaction models are not, as far as I know, not developed to give you some prediction about sedation.
Oh, okay. I will save this question for Professor Mariano in Italy. He has told me about some experience and some experiences he has had when using it like this. So we will save it
So
for
if
him.
if I may add one point,
Yeah.
I personally have never done it, but if you were to give sedation and use SmartPilot View, you could use the lowest two isoballs where they say TOS, tolerance of shake and shout, as a
Yeah.
target.
Yeah, maybe. Yeah. I've
But
never
I
used
don't
it
know
like.
how it works out. I've never done it
No.
personally.
I haven't tested it either. It's theoretical, it might be useful, but practical, I don't know. So time is flying. I don't think that we will be able to cover all questions. We're at 12:59 now, and I would like to say thank you to Rik Carette. It was a very interesting
It's my pleasure.
presentation. Yeah, I will thank you also for the team who made this possible in the background. Those ones we don't see in this in these settings, but I am very happy that they made it possible for us all to meet, and that so many had a possibility to show up. The questions in the that has been sent in, we will try to make our best to find the answer to all of those questions, and try to reply to those who has answered those questions. You're always welcome to contact your local representative in your region, wherever you are in the world, and they can put you in contact with a local SmartPilot View expert, hopefully, or you can contact me if possible. So with this, I would ask Gareth, if we are done here from your point of view?
Yeah. Oh, yeah.
Gareth is saying yes, and so thank you for attending, and thank you for tuning in to our webcast this day. Those ones who have the possibility or replied with a yes for the data privacy option, you will get the presentation and material sent you within a few days time. Those so that will be all for now. Thank you for Dräger Europe, and thank you, Dr. Rik Carette, and stay safe, everyone out there, and take care of you all. Thank you.